Hi, I'm Dr. Jim. I'm going to be talking about Porphyria cutanea tarda. Recently, I talked about phytophotodermatitis, one of the diseases which can be confused with phytophotodermatitis is Porphyria cutanea tarda. Porphyria cutanea tarda refers to a group of acquired or familial diseases in which the activity of the heme synthetic enzyme uroporphyrinogen decarboxylase is diminished. Normally, porphyrins are involved in the synthesis of heme, the non-protein part of hemoglobin, and hemoglobin, which is a protein involved in oxygen transport to body tissues. Here we see on the right of the slide that porphobilinogen is converted to uroporphyrinogen, and this is converted to coproporphyrinogen by uroporphyrinogen decarboxylase, and ultimately to heme and hemoglobin. In Porphyria cutanea tarda, uroporphyrinogen decarboxylase is deficient, resulting in increased porphyrinogen intermediates. The familial form of Porphyria cutanea tarda is usually an autosomal dominant mutation. Familial porphyria may also be autosomal recessive. Expression of both sporadic and familial forms of this disease most often requires exposure to environmental or infectious agents or the presence of coexisting conditions that adversely affect liver cells and result in overstorage of iron in the liver cells. Ethanol intake, estrogen therapies, hemochromatosis, hepatitis, and HIV are among these contributory factors. Smoking and aromatic hydrocarbons may also be contributory factors. These contributory factors increase oxidative stress. The increased levels of porphyrinogens are oxidized to photoactive porphyrins. These mediate photooxidative reactions, causing skin lesions, and are eventually excreted from the body. In this picture, provided by the University of Cape Town, we have examples of skin lesions which may be found in Porphyria cutanea tarda, including hypopigmented lesions, skin erosions, and blisters. The most common skin manifestations include mechanical fragility after sunlight exposure and erosions and blisters which form painful sores. The skin sores are painful and often become crusted and secondarily infected. Healing is slow and leaves pigmented changes and scars. Other common findings include hair growth and plaques. Water-soluble porphyrins are excreted in the urine. These may be visible as a red pigment resembling port wine. Porphyrins absorb energy from the long ultraviolet and visible light waves so that sunscreens must contain ingredients that either scatter or block long ultraviolet and visible light rays. Barrier sunscreens with titanium dioxide and zinc oxide are recommended. Diets low in iron and alcohol are also recommended. Smoking cessation should be stressed. Adequate dietary vitamin C should be consumed. Treatment of Porphyria cutanea tarda includes the following: therapeutic phlebotomies, which reduce iron stores and improve heme synthesis. The goal of therapy with phlebotomies is to reduce ferritin, a measure of iron stores, to the lower limits of normal. Low doses of chloroquine and hydroxychloroquine may be used to treat this disease. Desferoxamine, an iron chelator, is an alternative treatment. If the patient becomes anemic, erythropoietin may be used to promote hemoglobin synthesis.